And people all thought that these receptors are actually looking for molecules that Charles Genway talked about in this new standard model of immune system. But as I said, it cannot really explain a whole lot of context that we always encounter in our lives. That means the standard model is not true. What is a standard model? Standard model will explain whatever it encounters. That's how the standard model is so kind of popular word in physics, right? Because they want to negotiate between different scales of size from gravitation to quantum mechanics. And I think the best model that came in 1999 by this lady, I think this most prolific science, immunological philosopher and immunologist, Polly Metzinger, someone I actually adore, and I had opportunity to interact with her. So what Polly said, that immune system doesn't care whether it's looking at bacteria, viruses, cancer, or self-antigen. It only cares whether there is any chance of damage, tissue integrity loss, and that's when it comes up and gets activated. And that actually feeds into a lot of clinical contexts. There are few clinical contexts which still cannot really fit in, especially for some of the immune cells functions. For example, natural killer cell function cannot be explained. It's not important for this audience. But still, this is far more better model compared to Medower Barnett, Charles Genway were celebrated immunologists. So Metzinger's danger model. I think now people are hearing this danger model, danger hypothesis more often because now it has become really popular and accepted. And so the point is that all these cells, when they're damaged, they will release danger signals, and that's when immune system will get activated. And there are a whole lot of danger signals which are not from outside, which are from our own body, have been now discovered and worked with. And the story doesn't stop here. It's still going on. And I'll just end here by saying...
No, you have 2 minutes.
Okay, I have 2 minutes. Okay, thanks. I'll take 3 minutes of Yogiraj, perhaps. He's a very close friend of mine. So the story doesn't stop here. So this guy has proposed back in 2013, when I started my independent lab in Kolkata, a new standard model of immune system. He's still working on it. He's Toma Pradu. He heads the philosophy of biology unit in a hardcore CNRS immunoconcept immunology laboratory in Bordeaux. I also had the opportunity to make friends with him, and Toma suggests that immune system is always looking for change in the body. Whatever is change, immune system gets activated. If the change is not ominous enough, it shuts itself off. But we are not sure. He's still working on it. I'll just point out one thing, that Toma is actually a trained philosopher. He is not a doctor, not an immunologist. He did his PhD in philosophy from Sorbonne, Paris. And his thesis on philosophy was history and philosophy of immunology. So you can understand, so many different kind of people are coming together to solve this problem. We behave as if the problem is not there, but the problem is very much there for almost 100 years. I'll just end by saying that we are still in the search of the Holy Grail. So we started with self, non-self model, which kind of is ingrained in our brain. We think the immune system as something which fights off infections, etc. We are not very sure when you take into account all the biological findings, all the clinical contexts, all different kinds of patients that you are looking at, and you can't really fit in with this self, non-self model. I'll just end here. Any question? I just wanted to give a very general talk so that you get this idea that things or ideas are evolving with time. And thank you for inviting me here. Thanks so much.
Thank you very much, Dr. Ganguly, for a very lucid presentation. You presented it very nicely for all of us, particularly the clinicians and the pathologists and microbiologists who are present here. So if there are any questions, you can ask. Any questions? So I will request everyone to maintain silence, particularly in the back. There was a lot of commotion during one of the talks, so please maintain silence while the speakers are speaking. So now it's time for felicitating because there are no questions. We can have always questions later on during the lunch hour. I will request Dr. T.K. Ghosh sir to felicitate Dr. Ganguly. থ্যাংক ইউ আপনারা আর যখন দেয়া হচ্ছে তখনই ছবি তুলুন, পরে তুলবেন না, সময় নষ্ট হচ্ছে। So the last talk in this session is again from a supporting partner. So that is Path in situ, establishing tissue pathology lab in an economical and efficient way. So Mr. S.K. Das, over to you.
Thank you very much. Thank you for this providing and a very good this opportunity. Thank you. Thank you for providing a very good opportunity. This is a Capcom team. So we are here to this introduce all these products as well as how efficiently and effectively we can able to this make into histopathology this lab. It's not only this immunohistochemistry, even though we started with this immunohistochemistry. So first we have to this thank for the people, those who are this extended our this support. Thank you all, our this partners, our supporters, who are this making us in the very good way in a span of this last 10 years. So this Path Institute is not only this antibody this manufacturer or any this instrumentation. We are well versed with this hybridoma lab. We are this creating or developing our own clone. Our own this clone to this meet the Indian this society, Indian this scenes, so that it will be this helpful for all to this get an effective this way. We are also this designing and developing a very good this useful instruments like auto stainer or this immunohistochemistry stainer or the printers, then hybridoma this labs, all under this one roof. We are this making it so that it is the perfection can be this taken place in all the way. We also this acquired. There's a lot of this labs which is similar to this proteomics. The proteomics can be this accessible for the biosimias and introduction of this monoclonal and polyclonal antibodies. We are the providers for this the complete this solution provider for the histology to this molecular, because now the pathology is this not only confined or this is stopped only with this pathological this things. It extended to this molecular this pathology also, and we the providers for the solution for the entire this thing, including this molecular this pathology also. So we come out with this complete certification like this FDA, CE, GMP, then ISO 13485, then the MDR this 2017 Class C to this meet a perfect this diagnostics in vitro diagnostics this studies. So we came out with that study with this experience the link to experience the future. It is there's a motic. There's a based on there's a motic the relation with the help of this motic association. We have this made a complete this solution for the digital scanner. Digital scanner is this upcoming this one, and we all requested you to this come and visit our stall to find out that the scanner how it will be effectively and efficiently can be this useful for the labs. So this we are having that a scanner with this different this types like this single slide, 6 slides, 60 slides, and 100 and so forth. So it will be this easier to this do. The major advantage of this digital this scanner, the reporting from anywhere else, because now it is this upcoming after COVID, a lot of this improvement on online scanner or online this reporting has been this taken place. We are also sitting with this motic to this provide such an excellent this one, shorter in turnaround time, long term of this respiratory data, global access for this second opinion, all the aspects. And in this scanner, we are this providing the 3 different this cameras, so which can this autofocus and at the same time to cover the entire the slides, which can be this able to this provide you at a shorter time of this say nearly within this 1 minute. So in 1 minute you can able to this view and scan and this resend that one even at 160x also without having any this pixel break, without using any this oil immersion, you can able to this find out that the slides clearly and share that the pictures. So we are this not only this providing the solution for the manual, we also this providing the solution for automation immunohistochemistry, because automated immunohistochemistry which always helps to reduce this turnaround time, and at the same time to this reduce the complete this manpower this mistakes, man-made mistakes, so that no, that will this reduce the repeatability or non-false negative this cases. In this way, we can able to this provide the better one. We are this providing in the form of this 30 slides capacity, 3 different rack, and on the rack are continuous this mode. By using 120 microliter, you can able to this cover the entire slide. That means both patient sample as well as the control can be this performed in the single slide. So it is effective and documented this evidences to show how our this slides are, how we are this perfect over there. So we are this providing the entire this range of this antibodies for this different panels. Say nearly this more than 400 plus antibodies, and we path institute all this mainly this named as a rabbit monoclonal this company. The reason is we want to this provide a better, efficient, and target oriented monoclonal antibody called rabbit monoclonal antibody. The rabbit monoclonal antibody are having high specific and sensitive. Whenever this specificity has been improved, the target, the crispness will be much perfect. Once the crispness has been this perfect, the localization is perfect, then the background stain or non-specific stain can be completely reduced, so that scoring can be this opt and you can able to this give the better thing. We also this provide a unique this technology called micropolymer detection technology, where the polymerization has been this micro fragmented, which can able to this get a faster binding, and at the same time that will completely reduce false negative this cases. So there's a unique one and a very useful one that also this we are this introduced and we are sustained in the market. So apart from that, we also this provide the entire this range for the histology also. Histology this right from the grossing station. Whenever this you are finding the grossing station, nowadays the grossing station importance is also there. Without having this a proper grossing station, even that a cap or any this other this accreditation cannot be this accepted. While providing the grossing station also, we want to this give something this is special or something this is good. One is the height adjustment. The platform can be this adjusted 1 to 1.5 feet up and down. Second thing, while grossing, either by this professor, sorry, the HOD, or otherwise any other this technical this people, those who are this doing the grossing also, we have to this provide one sort of a cover shield, a glass shield, just like this laminar flow this instrument. One shield will be there, so that it can this cover up to our chest, so that no spillage or anything will be affected to us. Then the tissue processor, embedding station with this advanced one, microtomes with this different way of models, and slide dryer also. So apart from that, both microscope, as for after this instrumentation, we came out with the we associated with the MOTIC and extending this support of complete range of this microscope, right from this basic microscope to teaching microscope and all sort of this thing up to digital scanner. That is a upcoming this one. So we also this provide that a special stains almost all the labs they can able to this prepare on their own, but for that they need a specialized this technical this expert, and the consistency should be there. To avoid such things, we are this providing a ready-made this forms of the special stains. You can able to this get the consistent this results and at affordable this cost. So we also this provide the immunofluorescence tagged reagents for both the kidney as well as this skin biopsies. Complete range in this sense, IgG, AM, C3, CC1Q, fibrinogen, kappa, lambda, all this antibodies. with a FITC tag. We also this provide that a fluorescent microscope to take that one. So we also this came out with this technology of this fish to support as a hybridizer. The hybridizer is nothing but this humid chamber which can able to this provide that temperature throughout that incubation this time of this 16 to 18 hours. That also can be this possible. This is unique this one and a very nice product. What we are having this a tissue microarray. Tissue microarray is normally this is useful for the evaluation this is a purpose and showing comparing the efficacy and in this drug diagnosis also, drug efficacy also. Here we are this providing this a different mold, different punches. You can able to this go for even right from this 4 tissues in single slide to 59 tissue in the single slide. So this is the one where you can this do the validation of this antibodies also. Target validation, how in this sense by taking different of this different of this range of this positivity right from this 0 to +1, +2, +3 also in this same slide. Along with that, you can also this add the negative this controls to see that they think you are this efficiency of our slides. So Path Institute is always on time with assured this quality. So inquire about us for the complete lab tech this technology. As we this is said, Path Institute is the company to provide efficient and effective this tool for our this immunohistochemistry or the entire this lab setup. The reason why we are not only this providing that instrumentation at affordable cost, we are also this providing that updated technology with a complete training to the technical this people. And we are always on the toe to this train that technical people, whether it is a PG or by this technical people to provide this extensive this training. Even now also in our ongoing this process, the next week, 26th of this July, we are conducting one this immunohistochemistry wet workshop in Suraksha Diagnostics here in Kolkata. If at all anybody this wants to this join over there to this find out this technology and hands-on this training, please join us. Definitely you will be this gaining good information about our immunohistochemistry. We will be this providing the entire this solution for immunohistochemistry. Not only this procedure, especially the troubleshoots. Troubleshoots is the major thing for the immunohistochemistry because we don't know where we are this going wrong. In that case, we are this educating or training the people in such a way that they can able to this get the better results, consistent results, even in manual also. This is the speciality of our this Path Institute. Because Path Institute, they are having the complete team with a full-fledged trained technical people. All our application people, not even a single salesperson in our team. That means we are providing on toes to complete service to the pathology people. Those they want to utilize, please join us during our this next week this program, which will be this held at this Suraksha Diagnostics, the complete hands-on workshop organized by this Suraksha, supported by this Path Institute. So we always this welcome you people to this inquire and for the establishing the better results of this pathology, right from this histology to this molecular, especially this immunohistochemistry. Please contact us. We'll always help you to this support. Thank you very much for your this kind patience and support. Thank you.
Thank you. Thank you very much, Mr. Das.
Thank you very
So it's now time to felicitate you. I'll ask Dr. T.K. Ghosh to felicitate you. So meanwhile, I have two announcements to make. One is that you have to visit, please visit the stalls which are just outside and some inside also. And another thing, the CAP members who are here who have not paid their annual membership fees are requested to pay the fees today. By cash also you can give to either Ms. Kamalika who is there or to any of our treasurers, Dr. Moitri Shah or Dr. Saurabh Bhaumi. Thank you very much. That's the end of session 2. So we have made up some lost time, but we are still running at least 25 minutes behind schedule.
But sir, there is time to felicitate you. Please wait, sir.
Okay.
Dr. Shumeda is felicitating Dr. T.K. Ghosh sir and Dr. BNC sir. A big round of applause, please. We are suddenly very quiet. Thank you for your presence, sir. We shall now move on to session 3. Your anchor for this segment will be Dr. Shumeda.
After a very enriching second session of the day, we are moving on to the third session. And the chairpersons of this session, I want to call up on the stage Dr. Colonel Deepak Kumar Mishra, sir, and Dr. Divya Midha.
Good afternoon, everyone. A big thank you to the organizers of CapCon 2024 for having Dr. Mishra and me here. You've done a wonderful job. But without wasting much time, since we are running late, I'd like to introduce the first speaker of this session, Dr. Anand Bardia. Dr. Anand Bardia needs no introduction. He's a colleague of mine and a wonderful oncopathologist at the Tata Medical Center, Kolkata. He is going to speak on cancer and autoimmunity. The stage is ready for Dr. Anand Bardia.
Hello. Thank you, ma'am, for the kind introduction. Very good afternoon to all the respected answer. And a very good afternoon to all the respected faculty members and the delegates present here. So without wasting much of time, let's start with our topic. So first, case history. There is a 50-year-old male who noticed a pigmented skin lesion in his right toe. And he has been seeing it since last 1 year. It is gradually increasing in size. Ultrasonography showed that there are some mildly enlarged inguinal lymph nodes. And he also has a recent history of an organ transplant, that is of kidney. So a biopsy was done, and this is the lesion of the skin. You can say it's a hyperpigmented lesion. And on biopsy, it was found that these tumor cells were infiltrating the dermis, and they have very prominent nuclei with some pigmentation. So no-brainer, it's a malignant melanoma. So the patient was treated for malignant melanoma. But what's the question here? The question is, why this patient developed melanoma? So, is it due to the environmental factors, or is it due to something else? Is it related to his previous kidney condition, or on the fact that since he's a transplant patient, transplant recipient, he is on immunosuppressive therapies? So, is his immunosuppression linked to the development of melanoma? So, what is the root cause of it? So, like this, there were many cases, and the researchers tried to establish a link between melanoma and immunosuppression. And so, in this topic, we are going to discuss a little bit about the cancer and autoimmunity. Are these two sides of the same coin or not? So, going back to this article by Enitska et al., and what they found was that immunosuppression is linked to increased risk of melanoma. And usually it is seen in those patients who are transplant recipients, who are having lymphomas like NHLs, particularly CLL, or those affected with HIV virus. And it was also seen that the overall survival in these patients was worse compared to others. Apart from this, it was seen that the main factor which is causing an increased risk of melanoma is the answer of it lies in the tumor microenvironment. So how this melanoma is altering its tumor microenvironment, and ultimately leading to development of malignancy. So this article by Louis Lanier back in 2001 actually tries to explain this with the help of immune surveillance hypothesis. It's a review article where he describes the various studies which was done. And in it he says that 40 years back when McFarlane and Lewis Thomas, they proposed this theory of immune surveillance, where the immune system tries to protect the body by identifying those foreign carcinogens and killing those cells. So is this immune surveillance, because of immunosuppression, getting weakened, and that gives an opportunity to the cancer cells to develop, proliferate, and ultimately leading to malignancy. And in this article, he says that the studies of Giardi and Griffey highlights the role of T cells in the regional immunity. So in this pathway, he says that the cancer cells have certain antigens on their surfaces, which are being recognized by the NKG2D receptors on the various effector T cells and the natural killer cells. Once they get stimulated, they activate the signal transduction pathways, leading to release of several cytokines, which leads to the apoptosis of these cancer cells. I'm not going to details for the sake of time we have to discuss more things, so I'm not going to details of this pathway. So what I described in this was the part of innate immunity. Then there's another aspect of immune surveillance, that is the adaptive immunity, where the dendritic cells and the antigen-presenting cells, they're first primed with the cancer antigens. Then they go to the lymph nodes, where the T cells, the effector cells, they get matured, and then they go back to the site and kill those cancer cells. Also, they stimulate the B cells, which produce antibodies and kill those cancer cells. And this is the interplay of the various interleukins and the chemokines, which interact between various cells to ultimately lead to death of cancer cells. It involves the natural killer cells, the effector T cells, the B cells, macrophages, all the components of the immune system. And the chemokines like the interferon gamma, the trails, the interleukins, then TGF-beta, TNF-alpha, beta. So, have we got the answer? Is it that the immune surveillance plays an important role in killing the cancer cells? So if we have got the answer, then why is it that in some cases, there is increased risk of cancer associated with immune-mediated diseases? So we have seen this study by Ming et al. Summarizes the various studies, which say that it is due to the hyperactive immune system and the persistent immune activation that is leading to increased cancer risk. In this article, they say that yes, cancer is associated with certain immune-mediated diseases, and these immune-mediated diseases, they not only increase the total risk of cancer, the risk of total cancer, but there is an increased risk of the local cancer compared to the extralocal cancers. And yes, these immune-mediated diseases, in the long term, can lead to cancer in different organs and organ systems. So is it that the immune system is actually promoting cancer growth and cancer development? So, where are we? And there are various examples to it. There are various studies which have established the role of immune system in promoting cancer growth and proliferation, like the breast cancer. Then we all know in stomach cancers, the role of H. pylori causing chronic gastritis, leading to mucosal atrophy, hypoacidity, hypergastrinemia, and ultimately leading to increased lymphocyte proliferation and lymphomas and gastric cancers. Then the role of autoimmune gastritis in the development of gastric cancers. Like in this photomograph, we can see that there is flattened mucosa, as we see in autoimmune gastritis, and there's a lot of increased inflammation with atrophy of the pits, there's intestinal metaplasia, that ultimately leads to development of cancer. And then there was one study which said that it was seen that rectal cancer has reduced incidence if we compare to the other cancers of the GI, like the stomach and the colon, in chronically immunosuppressed patients. And we all know the role of inflammatory bowel disease and the development of GI cancers in the long term. As we can see over here, this cross specimen, there is a flattened ulcerated mucosa with pseudopolyps. There's one large nodule. And in the microphotograph, we can see there's presence of active colitis. Then there's chronic activity and ultimately dysplasia in the glands. Then we all know the role of chronic hepatitis leading to cirrhosis and the hepatocellular cancer in liver. So, is this immune system is a marksman? It is not helping our body to fight the cancer, but it is actually promoting the cancer in our body. So, is the immune system really helpful in carcinogenesis? Well, to understand it and to answer it, we have to understand the tumor microenvironment. Well, immune system is helpful in cancer pathogenesis or not? The answer is not a straight yes or no. It is yes, at the same time, it is no as well. So, the answer lies in the understanding of the tumor microenvironment. We have to understand that this tumor microenvironment is variable. And this variability determines the level of anti-tumor response. And we must also admit or know that the various immune cell components like the natural killer cells, the dendritic cells, the effector T cells, all have the capability to raise an anti-tumor response. So it is this balance between the immunosuppressive effect of the tumor cells which they try to induce in their microenvironment and the immune cells which are trying to fight those foreign antigens of the cancer cells and try to kill it. That determines whether immune system will actually activate or promote cancer proliferation or it will be detrimental to it. The cancer cells will try to support those populations which benefit them, like the myeloid-derived suppressor cells, the regulatory T cells, which leads to increased angiogenic factors, which will keep intact their blood supply and nutrition. And so, with this, we come to the concept of magic bullet. We all know, I know it, in previous session it has been highlighted, Paul Ehrlich. So what is this magic bullet concept? Well, it was back in 1900s when German researchers, they developed that differential staining which we use so widely in histopath. And Paul Ehrlich reasoned that if we can stain different organisms with that same stain we have, which stains differentially different parts, then why is it we cannot develop certain molecule which can deliver the toxin to the target cell and yet it will not affect the other cells in the vicinity? So he said that there must exist some magic bullet. And his magic bullet concept is now called as immunotherapy. So what is immunotherapy? It is a novel class of treatment drugs where these drugs actually strengthen the immune system of our own body so that they can fight the cancer cells. So how they do it? They use certain materials which are prepared either in the body or in the lab, and with these they try to improve or restore the immune system function and even target it if it is detrimental to the body. So how it does it? By these various mechanisms, they either try to slow down the process of cancer proliferation, or they will try to prevent it from spreading to other parts of the body, or they will help the immune system to kill those cancer cells. Now, there are various types of immunotherapy available. To name them few, like we can give immunotherapy in the form of monoclonal antibodies. We all know how they work, so I'm not going into details of it. The non-specific immunotherapies, the cancer vaccines, oncolytic viral therapy, immunotoxins, radioimmunoassays, then toxin antibodies, and the various other methods are there by which immunotherapy can be given. Now talking a bit about non-specific immunotherapy, it means the various cytokines and chemokines which are involved in causing cancer death, like the interleukins, then the interferon gamma. In cancer vaccines, we know there is one preventive vaccine which is very relevant to us people in the lab. That is the hepatitis B vaccine. It helps to prevent hepatocellular cancers in us. Then there is a Gardasil and Cervarix vaccine which helps to prevent the cervical cancer. And recently we have seen that there is one treatment vaccine which is developed against prostate cancer also. Then we have oncolytic viral therapy where the virus is genetically modified and programmed to kill a particular cancer cell. And one of such has been developed for melanoma patients, that is T-VEC injections, where the doctor injects the T-VEC into the multiple melanoma lesions directly, and those viruses kill the cancer cells without affecting the native cells. So, if we see at the immunotherapy, they try to retard the process of cancer cells, whereas the cancer cell will try to eliminate and escape the immune system, the immunotherapy, actually what it does is, it targets the cancer cells, it will activate the native immune system, and will try to maintain it at a sustained level so that it ultimately kills the cancer cells and thereby cures the patient of the cancer. And how it does it? It does it through various mechanisms. Immunotherapy agents, they take use of all the effector components which are at hand to develop this immunity against the cancer cells. So, have we got the answer? Yes or no? So, is autoimmunity good for us or bad for us? So again, it's yes or no. It's again the two sides of the coin. So we need to understand that if we look back, what previous people thought that in decades ago, that autoimmunity is something where there is response against the self-antigens. And cancer is something where our immune system cannot detect those cancer cells, and so there is malignancy. And so they are separate fields. But actually, with understanding of the immune pathways and the cancer pathogenesis, we now know that the molecules which are involved in autoimmunity and cancer pathogenesis are actually the same. And if we can further exploit it, and we try to more explore these two sides of immunotolerance, we can develop more novel therapies, immunotherapies, which will help us to cure the cancer patients completely, what we say as complete pathological response in our terminologies. And this same thing has been beautifully envisaged in this article by Justina et al., where it describes that autoimmunity and cancer can be looked at the two sides of the same coin, where cancer cells, they try to weaken the immune system so that they can escape it and promote those components of the immune system which will help in their function, like angiogenesis, whereas there are effector cells which can be strengthened and programmed so that they can kill those cancer cells and ultimately cure the patient. And these are various molecules in a healthy person, which if increase can lead to cancer, and if decrease can lead to autoimmunity. So what are we looking at is at the two sides of the same coin, that is cancer and autoimmunity. And hope, it is the quintessential source of man's greatest strength. And yes, at the same time, it is its greatest weakness also. So it depends upon us how we take this hope along with us, as a strength or as a weakness. Thank you.
Thank you, Anand, for that wonderful talk.
Thank you, sir.
Since we are running out of time, probably the questions will not be there.
Yes.
Thank you very much. That
Thank
was
you,
a great talk.
Thank you, sir.
No, hold on. Your memento. Yes. So we move on to the next talk, which is by Dr. Ranajoy. Dr. Ranajoy is a faculty in IPGMER in SSKM Hospital. He did his pathology from AIIMS, New Delhi, and has done his diploma in Royal College of Pathologists. And he is a graduate from Bankura Sammelan Medical College. And he is going to speak to us on autoimmune hepatitis. Since we are running out of time, without much introduction, I think Ranajoy, please start.
Thank you, sir, for those kind words, and thank you to the organizers for giving me this opportunity. So, if we see the spectrum of autoimmune liver disease, there are many conditions, but today I will focus on autoimmune hepatitis in special, and being a histopathologist, I will be little preferential towards histopathologist in this diagnosis. So we all know autoimmune hepatitis is an unresolving hepatitis with a chronic disease with elevated liver enzymes, hypergammaglobulinemia, and serologically autoantibodies are present and a mass predominance in women. Sorry. The etiology is always known, but pathophysiology, like any other autoimmune disease, which is discussed here for a long time in the morning, has the apparent autoreactivity of genetically susceptible individuals with molecular mimicry to viral and self-antigens. And the target here for this autoimmune clone is the hepatocytes. Now this cartoon shows the process of division and immunity. I'm not an immunologist, but I want to focus on two things. Firstly, genetically susceptible.